So if it works, we can make it available to you if you want to reprise this session. I don't know if you may not want to, but there is that option. So does everybody know Dr. Burrows?
Hi, I'm Heather Burrows. I'm one of the general pediatricians.
So she's going to be kind of monitoring the session. I don't know whether do you want to introduce yourselves, or you want me to introduce you, or?
Sure.
I'm Chelsea.
Paul. Sami.
And I'm Ginny.
Neil Grayson.
So I'm here not to observe you guys actually at all. Dr. Craig and I are both in the Academy of, I can never remember what the actual title is.
Peer-to-peer review.
It's a peer-to-peer review kind of component as part of the Medical Educators Society here. And so we're sharing the process of looking at how we each do our teaching.
Okay, so I'm trying to remember, Sammy, you weren't here last time, right?
I wasn't here for the afternoon.
Yeah, so I'm just going to explain, what we're going to do. So, and it'll be a refresher for the people. Basically, this is something that we've done for a number of years as an exercise in sort of diagnostic reasoning, as well as sort of it's a very common thing that's seen in pediatrics and in the ER. And it's kind of a diagnostic conundrum in a way, such that almost every pediatrics national meeting there's something presented relating to it. So this is why we want to work it through. It's a topic that's been an interest to me almost ever since the question was asked me when I was in an internship interview, and that's been a while ago. And then subsequently, about somewhere in the 1980s, we got very interested in trying to develop a computerized program that might help clinicians solve this problem. This was there was something called Internist that was developed at the University of Pittsburgh to assist clinicians in diagnosing various problems, which it never got very much off the ground, so I have a feeling it didn't go too far. Anyway, I don't know how familiar you are with computer programming, but basically it's based on like -1, +1. And so what we tried to do is we sat down with someone that was into computer programming, and we started off in various symptoms relating to this problem. And so the challenge was to decide, well, if this particular piece of history definitely pointed to our diagnosis, that would be a +1. If it definitely eliminated it, it would be a -1. The problem is that most of those, almost all those symptoms were somewhere in between. And so there was lots of discussion about whether it was like a +0.1 or a +0.3, to the point that it took us like maybe a month to get through the history, and then we quit. We just decided it was not doable. I mean, at least with the present technology. Whether in the future it will happen, I'm not certain. But anyway, so what we're going to do is, first of all, develop a list of general diagnostic categories, which we'll set up over here. And I kind of set it up in a way that's almost like a mnemonic, which we'll see when we fill in. And then, having done that, then we'll take this simulated patient, and I'll represent the parents, so that when you take a history, I can answer the questions. The way we'll do this is, first of all, we'll start off and have you as pairs come up with a list of the general diagnostic categories. Then we'll list them down. Then when we take the history, before we take the history, we'll sort of have you, as pairs again, make a list of questions that you would like to ask for the history, which could include the present illness, could include past history, family history, social history, review of systems, anything in that genre that would help you figure this problem out. And the questions should be phrased such that, representing the parents, the father is a truck driver, the mother is a waitress. So the questions have to be phrased with that in mind. In other words, they can't be have to be at that level. And so we'll give you a few minutes to develop these. Well, actually, more than a few, as much time as you need, actually. And then we'll just alternate back and forth. In other words, as you pair can ask a question, and then we'll go to the next pair, so that everybody, you know, has a chance until we get to the point that say, well, that's all the, you know, everybody's got their questions answered. Then we'll come back and look at this list and sort of, and then have you decide, again, pairing up which things you think, are there any things, any categories we can eliminate? Are there any categories that seem more likely, or does the category stay about the same? Then we'll have, well, just prior to that, we'll sort of summarize, have somebody, a group summarize where we're at, and then we'll go to the exam, and then have you again list down some questions that you would want to, what you'd want to do for the exam, and I have a preconceived diagnosis in mind to make the thing work. We're not going to have you randomly, you know, go all over the place and not end up at some point, okay? So, and then after we look at the exam, then, you know, have you think about going back to this list, what can we eliminate, what's more likely, and so forth. Then have you sit down and kind of figure out what labs you'd like to order, what imaging studies, if any, you'd like to order, again, to further figure this out. And then once we have that, then kind of decide what the diagnosis might be, see if we can come up with a diagnosis. So it's an interesting exercise, and I think you'll find it kind of intriguing as we go along here. So any questions about what we're going to do? So what this is basically is kind of drawing out, almost, you know, prolonging what a clinician would do if they were trying to figure this out. Admittedly, an experienced clinician, they see the age, they see this history, they're going to develop some preconceived notions. There's basically, in terms of decision-making theory, there's sort of the concept of fast thinking, slow thinking. In other words, the experienced clinician has all these like illness scripts in their mind, and so they see something like this and they're automatically have a differential built up, which can be very helpful, but at times can be a problem. In other words, they may anchor on a diagnosis that's not right, and then they can fall into a trap of trying to make the patient fit their preconceived diagnosis, which can be a problem. The second type of thinking is more analytic, where you wait, gather all the information, and then think about it. And sometimes they actually intermesh. One has to be careful. There's this saying that was sort of paraphrased, I think, down through the centuries, but basically, if you hear hoofbeats in Ann Arbor, it's usually not a zebra, but every once in a while a zebra shows up. So that's why you have to be careful. So the first thing is, as pairs here, why don't you think about some of these diagnostic categories that we could lay down here.
To clarify, do you mean specific causes of a limp in a child,
No.
or like inflammatory or
Yeah,
something?
very general categories. In other words, otherwise, if we listed everything that could be possible, we'll be here all all day. So maybe as a two-group unit, maybe, you know, in other words, working together basically. See what you come up with here for a few minutes, and then we'll fill in the gaps.
Do you have a moment?
I've seen some. There's not one I would just spend here.
My CFM instructor taught us how to
Do you
communicate.
I think so.
Okay.
I don't think it was tied back either.
Yeah.
So I think
And
one
for
tied
infections,
inflammatory. Yeah.
and we'll do vascular. Mental health.
Oh, yeah.
Is that it?
Sure.
Idiopathic.
I don't actually know what
Not really category.
Sure.
It could be a good.
I can actually see if I can get them.
They're giving you a few hints.
All right, then let's skip the A for now.
Okay,
And
now make your-
vascular.
Oh, I guess it could be. I don't know. Changing my mind. Sorry.
I like that metabolic.
I've seen like congenital / hereditary, not necessarily for this particular demonic.
I like it.
Specific. I've seen electrolyte abnormalities. It's pretty good.
Vitamin D. What it can be.
I don't think that-
I might see
Congenital,
metabolic.
yeah.
Oh, this is endocrine.
Oh, there you
Maybe I shouldn't have put them. See here. Looks like
I
you're
like
pretty
that.
well.
I don't know much.
Looks like you're pretty
Yeah.
well.
Yeah.
Alright.
Okay, I don't know it.
You know everything.
All right, Ginny, your group wanna lead off, and you give me one?
V for vascular.
Okay, that's a good one. Now, what are you thinking about, when you say that? Anything specific?
So broadly, like either having occlusion of an artery or vein, having
Sure, but in other words, in
necrosis.
terms of a 5-year-old.
in terms of a probably like avascular necrosis.
Yeah, Lake Perthes.
Mhm.
Okay, good. All right. Okay, we'll let, Paul will let you.
Okay.
Chelsea will let you.
Infectious for,
Okay. All right.
I guess in this case, could be thinking about something like a septic joint.
All right. Well, Sammy, what do you have to read off her list?
Yeah, sure. Or something that could go for T. I often see traumatic.
Yeah, like
that
trauma,
goes,
yeah. Okay, so that's a good one.
Yeah.
Guess you're following right along here,
Mhm.
okay? All right.
We weren't sure about A, but maybe anatomic?
Oh, yeah, that actually is a combination of different things. That can be autoimmune. That's kind of a confusing one. I'm not sure I'm particularly happy about that. It's sort of a combination of this one, inflammatory, non-infectious. So I'm gonna fill that in, and actually we're kind of gonna maybe this is pretty much the same category, so it doesn't quite, the mnemonic doesn't quite fit, but, you know. So I'm just, I hate to give up vitamin C. Actually. All right. So, what do we,
Metabolic.
yeah, so what are you thinking, what could be, what could cause, limping, what metabolic problems could cause limping? It's a good choice. I'm just interested in what you're thinking about.
I'm not thinking about anything in particular other than the pneumonia.
Okay. See, it could be a vitamin deficiency.
Oh.
So there's a classic case, which I should have, that's one thing I didn't do, is from a CPC, that, and actually they revisited it not that long ago, where there was an autistic child that was about 8 years old that had a limp and came to the their primary care physician, and they couldn't find anything in particular, and so said, well, maybe he hurt himself in some way, and probably get better. So the mother said fine, so it went away, and then didn't get better, started to get a little worse. So she came back in 2 weeks. They took an X-ray of just like bodygram almost. Didn't see anything, so they said, well, he said, maybe try a little Motrin, inflammatory maybe is something going on that's we don't quite appreciate. So then, so mother said fine. So then it got to be a point about a month later, that child refusing to walk. So then came to Mass General, and they took an X-ray, and so the child had was scurvy, and the reason was, the child was autistic, see, and had a very fastidious diet. So it's a pretty rare thing. again, see when, you know, the problem was they couldn't get a history as an autistic child.
Mhm.
And so when you get something like that, then you start thinking of unusual things. So that's what metabolic. So you wouldn't be thinking of that, I don't think, ordinarily, and it's pretty rare. But we'll have it up there because it is a possibility. All right. So.
Neoplastic?
Right. Now, the other thing to understand about that is that includes not only malignant processes, but also benign, so just be aware of that. Anybody come up with D, C, and H? Starts to get tougher.
I said developmental.
Actually degenerative, but this doesn't really apply. We're gonna get to, doesn't really apply to this age group, but it's in there just for completeness sake.
Congenital? Congenital?
Yeah, that's the, okay. We got one last one.
Hereditary?
No, it's hematologic. You know what that might be? Anybody?
Like ALL or something?
What's that?
ALL, acute leukemia.
Right, or how about a sickle cell crisis? Okay, so that's, so the other thing I'll just give to you right now is, this is pretty much, if you run into a musculoskeletal problem, this is pretty much the story here. So degenerative, I'm going to just take off because that doesn't apply to this case. So the next thing to do is, I'm going to take this one off too because we're going to just, it's sort of a duplication. So the next thing I want you to do is to, based on this brief history that you have, what questions do you want to ask in the history to try to work this out? It could be present. So just take a few minutes and kind of write them down, just like you did. Maybe and sort of, we'll give you about 5 minutes to see what things you'd like to ferret out here.
Yeah. I don't know if it applies in this case. If there's pain, yeah.
So, other things typically would be chronic
Constitutional symptoms.
recent illness, like recent trauma.
For family history.
Chelsea writes as fast as I can type.
With family history of malignancies, like hematologic malignancies.
Yeah, I think keep in mind that what you're trying to do is to rule in or rule out these various possibilities. That's where your questions are sort of focused.
No, it's about trauma.
Yeah, I guess then even like more relatives, right?
Should have had very everybody sign a disclaimer that they've never run into a patient like this. Of course, you can, just get a general outline. Some of the questions will develop after you see the answers to some of the first questions, which is, which is fine. So everybody's got the OPQ. That's good. That got drilled into you.
Yeah.
All right. Well,
Yeah.
why don't we get started? Because I think you'll come up with some other questions, I'm sure, once you get the answers to some of them. So, Paul, since you weren't taking notes,
I offered.
You get to ask the first question.
Okay. So I think we wanted to start with is there pain or is there no pain?
Well, there's lots of pain.
There's lots of pain.
You want to know anything more?
Where is the pain?
Okay, so he has pain in the right anterior thigh. Okay, well, now we'll go over to Sammy's group since Ginny's still writing. So.
Sure. So, how long has the child been experiencing pain in
Okay.
the limb?
Right. So what happened was this child is taken care of in child care and daycare because both parents work. So this is a Saturday morning, and what the parents found out when they went to pick the child up from daycare was that, and obviously when they dropped him off in the morning, he was fine, and that this is a daycare center where there's two people that run it, and they have 10 children that do this thing, this house. There's a little yard in the back, and you have these little play things. So in the morning, they let them run around outside, and then they come in for lunch, and then right after lunch, they have this rest period. So what happened was when this child got up from the rest period, was limping. So we're talking about a time frame of, now let's say it's about 9 o'clock in the morning on a Saturday, so we're talking a time frame of maybe about 18 hours, something like that. So let's say yesterday started around 2 p.m. At daycares.
And the daycare workers didn't see anything, or
No,
was it
they
before
said
that?
that they didn't notice anything, that was complaining of any.
He didn't fall.
Not that they noticed, but I mean, these 10 children, they run around, and so not that the child reported or that anyone saw. So no definite history of trauma.
Has he otherwise been well? Has he been ill recently with fevers or chills?
He had an upper respiratory tract infection about 2 weeks ago, and he was started on some antibiotic, but the family doesn't recall what it was. But he's been off of it for 3 days.